બરાબર દેખાય છે.
બરાબર, ઓકે. Stop for a while.
Yeah, you can stop sharing. So we wait for some time. It's already live on YouTube, but we'll wait for 5 minutes to for others to join. Amin sahib, good morning.
Good morning, good morning.
કેમ છો સાહેબ? તબિયત કેમ છે?
સારી છે, all right.
Dakshaben and Satish are coming on 7th.
Oh, good news, good news. તબિયત સાહેબ બરાબર છે લોકોની?
No, both are good. Yeah.
ઘણા વખતથી જોયા નથી એટલે. કાલે તમારે ત્યાં પેલો પોસ્ટ ગ્રેજ્યુએટ પ્રોગ્રામ છે ને, આંબેડકર સાહેબ આવવાના છે.
હા, આંબેડકર સાહેબ અને બીજા
ડોક્ટર ચોખાની.
ચોખાની, yeah. Starting at 8 o'clock in the morning.
Yes, Tushar sent me the program, so I'll come to meet both of them.
Right.
Since they are here, yes.
If you can come at lunchtime also.
અમારે ત્યાં પ્રોગ્રામ છે સર, સોશિયલ ફંક્શન છે કાલે બીજા બે, આજે રાત્રે પણ છે. બધા બહારથી આવ્યા છે બધા, એટલે હમણાં 4-5 દિવસ બધાનું ગેધરિંગ રાખ્યા છે. ડિસેમ્બર એટલે પેલું NRIs બધા આવી રહ્યા છે.
ડિસેમ્બર, જાન્યુઆરી.
આ મીટિંગમાં તો જાહેર કરી શકું કાળજી કેરમાં we are starting from geriatric clinic from next
Sir is a very dedicated teacher, no? At this age also he travels and he guides students.
Yeah, Dr. Ambedkar, very.
He has also written a book recently, What All Doctors Should Learn. So I am reading it, and in future I will have a review on that book. It's all lessons of medical practice. How do we exactly should go? So, sir, shall we start? It's 4 minutes past 8 o'clock.
Yes,
We can
yes.
start. Yes.
Yeah.
So, good morning, friends. Welcome back to our Saturday Club morning meeting. And today we have Dr. Jagdish Bhai Patel reviewing a book titled How Doctors Think by author Jeremy Groupman. Jagdish Bhai actually doesn't need introduction to our group. He is a founder member of the Saturday Club of Baroda meetings and has been reviewing books very often. In past also, he had reviewed 2 books, and today he is going to review this title, How Doctors Think. To formally introduce him, Dr. Jagdish Bhai is a general surgeon, one of the senior most surgeons in Baroda. He is honorary secretary to Medical Center Trust, which runs a very prestigious institute called KGP Children Hospital for more than 40 years now. And he is a multifaceted personality. He has written few books also, mainly on life management. So, Jagdish Bhai, over to you. You can start your talk. Thank you.
Thank you, Satish Bhai. And thank you, members of the Saturday Club, for having me this morning. Einstein very famously said that thinking is a hard work, and most of the people don't do it. But doctors have to think about the patient and how they think. This book is 10-chapter book written not only for doctors, but for general public also. So the language is very simple, and medical cases which are described in such a way that common people can also understand. Why this book? What goes on in the mind of doctors as he or she treats the patient? Are they keenly listening, observing, or asking questions? Are they deeply thinking about their patient's problems? And usually trainees observe seniors and they learn from the behavior and interaction of the seniors with the patients. Seniors rarely explain mental steps that led him to diagnosis and treatment. Medical students and residents are being taught to follow preset algorithms and practice guidelines. Insurance companies also insist on preset guidelines for approval of treatment. Clinicians are directed to follow evidence-based medicine. Research studies usually guide treatment decisions, but statistics cannot replace physician's personal experience and his decision if it serves patients' needs. Statistics is about averages, not about individuals. It can complement decision based on experience. How we think. Competence is not separable from communication skills. If a person is very competent but is poor in communication, he may not succeed. And if there is a very good communication skill and poor competence also will result into failure. Majority of failures are due to flaws in physicians' thinking and not technical mistakes. So can physician be infallible if medicine at its core is an uncertain science? We can improve if we know how we think and learn to think better. Patients and families help doctors to think better. In lot many cases, doctor has described how patients and families have helped doctor to come to a correct diagnosis. Does doctor's mood and temperament influence his medical judgment? We have seen this. What influences our decision? Our decision is influenced by language patient uses to describe symptoms. Money is inseparable from medicine most often and may influence our decision making. And marketing by pharmaceutical companies may have some influence in decision making. More on this we will see in the last chapter of the book. Freedom for patient. Patient must be encouraged to speak freely and express their problem. They should feel that you are interested in what they are telling. Doctors should understand emotions of patients. On average, most physicians interrupt patient within 18 seconds of their storytelling. Doctor-patient relation is also very important. Sickest and chronic patients are not liked by doctors. Most of us have this kind of experience. And patients sense this dislike. They can understand that doctor is not keenly interested in them. Doctors also sense their failure, that whatever attempt they make, this patient is not going to be cured. Patient and doctor should like and have faith in their relationship to have a good communication and good outcome. Dr. Pett, who was emergency room doctor, now studies physician's cognition. He explains that in flesh and blood decision making, pattern recognition comes into play. All data coalesce into pattern that physician recognizes as a specific disease. It occurs within seconds, and this happens mainly in critical emergencies. Mind acts like a magnet, pulling in cues from all directions. No sooner patient is introduced, thought process starts. Doctor notices color of the skin, edema under eyes, timbre of his voice, and so on. He starts differential diagnosis as he examines the patient, and he is ready with provisional diagnosis by the end of examination. So thinking is inseparable from action. Thinking starts no sooner you see the patient. Now this is the case. Ivan was hiking in the woods when pain starts in chest and he stops. He is forest ranger in early 40s. This is important. Trim and extremely fit. He returned to his hut and waited, but pain did not reduce. Dr. Pett saw him in emergency department. He went through his usual differential diagnosis for chest pain. He found that his vitals are normal, so was his ECG, chest X-ray was normal, and cardiac enzymes also turned out to be normal. Doctor, saying that everything is normal, reassured him and said this pain may be from some overwork or muscle pull and not from the heart. But when Dr. Pett came on duty next day, colleague informed him that Mr. Ivan, whom you had seen, came with myocardial infarction yesterday evening. So what did Dr. Pett missed? And why he missed? Dr. Pett missed it because his thinking was over-influenced by how healthy and fit the man looked. Mr. Ivan was in the midst of unstable angina due to coronary artery disease. ECG is normal in 50% of unstable angina. Cardiac enzymes were normal because there was no damage to myocardium. And chest X-ray was normal as lungs were not congested. So one should be prepared for atypical case, not be quick to reassure the patient that nothing is wrong. In another case, in a patient with cirrhosis of liver, interns labeled him alcoholic cirrhosis because while patient gave history that he enjoyed a glass of rum with dinner, while he had Wilson's disease and was put on copper chelators. Interns thought that because he had a rum with dinner, he had alcoholic cirrhosis. Patients with alcoholic cirrhosis, smokers with emphysema, obese with diabetes, and those with psychiatric illness puts doctors off and want to walk away, considering that they are less deserving of their precious time. So there is a kind of disgust with this kind of patients. Really, doctors should put red flag in mind and recognize that feeling of disgust and learn to overcome it. This is another case of affective error. Mr. Joe, about 80 years old, in very good health, is a good friend of Dr. Myron. They meet almost daily. Lately, Mr. Joe complains of indigestion. Dr. Myron treats him with antacids and proton pump inhibitors. He avoided invasive investigation because he did not want to put his close friend in an case of endoscopy. Treatment gave him slight relief. He became weak in about 4 months when upper GI endoscopy was done to find a large mass in stomach, which turned out to be lymphoma. Fortunately, it was treatable cancer and Mr. Joe recovered, but time was wasted because of emotional closeness of friendship. Then there are problems of stereotypes. Miss Ellen, who is perimenopausal, said she has what she calls explosions, feeling hot all over the body and sometimes terrible headache. It is like bomb going off in my body, that is how she explains. She has seen 5 physicians and all said she is menopausal and 2 of them said she is a bit crazy. She says, what I feel is more than menopausal. This is something different. Then they started investigating and CT scan showed that she had pheochromocytoma above left kidney. So rare tumor of pheochromocytoma was diagnosed because of Miss Ellen saying that she knew that she fits in certain social stereotype of being perimenopausal, but her symptoms are certainly not of menopause. So in this way, patient may guide doctor to look beyond stereotype by their firm insistence, which in turn guides doctor to look beyond obvious. Dr. Francis Peabody of Harvard Medical School, in lecture in year 1925, said, the secret of the care of the patient is in caring for the patient. As we see more suffering and death, do we get immune to the feeling of the patients? And how do we balance this paradox? And most of the doctors learn to balance this paradox as they continue with their practice. Emergency room. Emergency room doctor quickly checks basics which are ingrained during his training, A, B, C, D, and E. A is for airway. He checks mouth, throat, trachea, bronchus. B for breathing, lungs are normal. C is for circulation, heart is normal with normal rate and rhythm. He looks for disability and rules out neurological problem. And he should not forget to expose all body parts for examination. So this is a case in ER. 10-year-old boy, well-built and well-nourished, was brought in ambulance with history of severe pain and collapse after another boy jumped over his back while he was leaning forward. There was marked tenderness on dorsal spine and X-ray showed wedge compression fracture of 10th vertebra. His blood count, calcium level, bone enzymes were normal. So why compression fracture in healthy young boy? His CT scan was normal, MRI of spine was normal. Pediatrician who saw the boy and reassured that boy looked otherwise normal. But his family doctor, Dr. Halter, was not happy. He said, let us keep looking until we figure out what is really wrong. In few days, boy came back with severe pain in the back due to multiple fractures of vertebra. Biopsy was done from vertebra and it was found to be acute lymphoblastic leukemia. Emergency room need not be hectic always. one need to slow down to avoid making cognitive mistakes. One has to work with studied calm, and patient and family will appreciate cool handling of the case. Because working in haste not only increase cognitive mistakes, but impair the communication of the most basic information about treatment. In study of 45 doctors, it was found that 2/3 did not tell patient how long to take new medicine and what could be side effects. And half of them did not specify even the dose to the patient. People take shortcuts. Classical clinical model is there are classical cognitive errors. Economist was awarded Nobel Prize for showing that shortcuts result into classical cognitive errors. Shortcut in thinking because of certain patterns, like you see many cases of pneumonia. You think of pneumonia in cases even when there is aspirin poisoning. Pediatricians have a blessing that most children who come to their office are healthy or have minor problems. Not to miss serious patient, they have to have a power of observation and has to be very acute. Observe the child while listening to the story from parents and use filters because parents are likely to exaggerate or misinterpret the observation and tell the stories. So, and however, at the end, when you have examined, be careful of the words you use to describe ailment to parents. If you find child is slow to learning, don't use word like autism. Or if you find that child is fidgety, don't use word like ADHD because parents will carry this all their life. This is an interesting case, a new mother's challenge. Rachel Stein spent 50 years in developing her career, and then she decides that her life is empty. So she decides to have adoption. She adopted 4-month-old daughter from Vietnam. During flight back to US, infant did not sleep because of cough. She stopped at Los Angeles to see doctor who got chest X-ray and said chest was clear, but prescribed some antibiotics. Next day, she reached Boston. Noticed that infant was not taking feeds. She went to Boston's Children's Hospital, most prestigious hospital, where tried a system of emergency room made her sit for 5 hours before resident looked at the child. He found that infant was dehydrated, had bilateral pneumonia, and while putting an IV line, infant had a cardiac arrest. Infant was revived because everything was available, put on multiple antibiotics and antifungal agent as there was fungus in the mouth. Infant was put on high-frequency oscillating ventilator. 100% oxygen by ventilator was not maintaining oxygenation because of bilateral pneumonia. As last option, resident suggested that let us put infant on ECMO and explain what ECMO is to the mother. The mother asked, what are the risks? After getting some idea of what extracorporeal membrane oxygenator is. So resident explained that following are the risks. Getting blood out on membrane has risk of infection in spite of all precautions, and small clots may form on membrane and produce small embolization when blood is pumped back. So there is core of uncertainty. Every clinical event has core of uncertainty. No outcome is ever completely predictable. Infant was put on ambu bag while they were preparing for ECMO. And with ambu bag, child's oxygenation improved. So ECMO was put on hold and infant was put back on ventilator. So they had a question why pneumonia was spreading. How is her immune system? Her HIV test was negative, even in Vietnam, but T cell count was low. So T cell, when challenged to attack bacteria, they appeared to be slow and paralyzed. Infant had pneumocystis, CMV, Klebsiella, parainfluenza, and Candida infections. So she was diagnosed to have a rare form of severe combined immunodeficiency. The gene for disorder is carried on X chromosome. And when it is carried on X chromosome, it would be rare for girl to inherit it. However, treatment for SCID is bone marrow transplant. Infant's birth mother in Vietnam was contacted for bone marrow donation, and she readily agreed. Possible complications of procedure, including host versus graft reaction, were explained. Mother said, "No, I think it is nutritional problem causing her immune system to having infection." They started infant was on tube feeding while preparation was on for bone marrow transplant. But as infant was put on tube feeding, her oxygenation slowly improved and chest X-ray showed clearing of ground glass. After 33 days in ICU, infant was transferred to regular ward and baby slowly gained weight with tube feeding. While transplant team was working, 3 donors were identified from National Registry and transplant team was now ready. So mother insisted that I want her blood to be retested. She does not have atypical severe SCID. Her blood was tested again and result was that total T cells were normal, helper T cells normal, suppressor T cells normal, and B cells normal, all working perfectly. So what was cause of immune deficiency? Malnutrition is leading cause of immune deficiency worldwide. Protein, vitamin, and mineral, all or any one of them can cause immune deficiency. Usually people look for only protein deficiency when they think of malnutrition, but even single vitamin deficiency can cause immune deficiency. What was cause of immune deficiency in this infant remain enigma. But lesson was that listen and honor feelings and research of parents. There is a cognitive bias. When you hear hoofbeats, think of horses and not zebras. This is common things thought because common things occur more commonly. And this avoid thinking of rare possibilities. Absence of personal experience with rare disease. And there is a kind of diagnosis momentum. One senior makes a diagnosis and writes on the case paper, and no fresh thinking about the case occurs by the juniors and residents. Innovations are required by pediatric cardiologists because congenital cardiac abnormalities occur at the rate of 8 per 1,000 live births. There is extraordinary diversity of abnormalities that demands innovation many times. And there may be no precedence of a case. You do best in given situation. Epistemology is nature of knowing how particular procedure came in a vogue And in this case, if you do epistemology, then you may find that there was a single case, and because it was rare. So commonest congenital defect of heart is atrial septal defect. Defect needs to be closed if there is 2-to-1 shunt. It means, what does a 2-to-1 shunt mean? It means that right side heart has twice the blood flow than left side. But one may wonder how this number was derived. At a conference of pediatric cardiologists in 1960, there was a heated debate when atrial septal defect hole should be closed. They could not come to any conclusion, so the organizers took a vote and median number was decided as 2-to-1. Pediatric cardiology is difficult because while doing imaging study, one has to imagine 3-dimensional image and manipulate catheter with visual spatial image in mind. Repeated practice and feedback will make one expert in the procedure. There is uncertainty. Human biology is inherently variable. Generalists, specialists, super specialists, all have to deal with uncertainty. And measuring outcome of the medical procedure is a difficult problem we face because of these uncertainties. Taking uncertainty into the account can enhance physician's effectiveness, shows honesty of the clinician, openness, and easy to change line of treatment if need arises in future. Coming to surgery, author himself suffers from pains and swelling and redness of right hand. He had injury while swimming. He consults 4 hand surgeons over a period of 1 year. Finally, diagnosis is labeled as dynamic scaphoid lunate instability. His X-ray and MRI shows cysts in 2 bones, and first surgeon advises bone graft to fill the cyst. But he thinks that his surgeon was desperate to do something. Second surgeon stopped searching once he saw cysts. Finding something may be satisfactory, but not finding everything is suboptimal in given case. And if surgeon was desperate to do something, he will not look beyond. Symptoms, clinical findings, and results of imaging have to fit into pattern to get satisfactory result. So the 5th surgeon conceptualized the problem and understood what surgery could do to relieve author's pain. He used synthetic material to obliterate cysts, and he repaired the ligament. 4 months of physiotherapy followed and resulted in 80% relief, not 100%. So result of surgery may not be 100%, and patients should be foretold not to expect perfection. Most surgeons learn dexterity through repeated practice. But most important is how they conceptualize problem and understand what surgery can and cannot do to remedy the problem. So surgeon's brain is more important than dexterity of his hands. Informed consent is very important. There is nothing in medicine and biology so complicated that if I explain in simple terms to patient and family cannot understand it. So not to disappoint a patient, most post-surgery don't paint rosy picture. Be honest and give realistic idea about the outcome. Now, we can perceive what eyes can see. The eye of the beholder. This is study of the radiologist. Radiologist first makes an observation, and second, he needs to analyze what he has looked. He risks missing something when he looks at a plate in haste. We may have to report on single image like chest X-ray or serial images of CT scan or MRI. One has to make a method of studying each anatomic component and report, or as some people make an impression at one glance. Study of performance of 100 radiologists. 20% of time they disagreed on the report on chest X-ray. 60% of them failed to identify that there was a missing clavicle. When clinical data were given, their performance definitely improved. Radiologists who were wrong were not only inaccurate, but they insisted that they were right. Study to assess doctors' ability to recognize cyanosis. 53% only were able to correctly diagnose cyanosis. 26% said there was cyanosis when oxygen level were normal. Reading of 100 EKG by cardiologists had very divergent views. In microscopy, biopsy of cancer cervix, 1,001 specimens were given to 13 pathologists. Generally, they did well when tissue was clearly cancerous or was clearly normal, but they did not do well when identifying precancerous lesions. To avoid errors, one must adopt systematic approach to the microscopy. Mammograms are most anxiety-producing X-rays because up to 20% of them made mistake. And the last bad experience of a case had profound effect on the result of reading mammograms. Study previous mammograms if there is unusual finding like calcification.
Yes, sir.
Lung cancer. Computer-aided diagnostic system improved the accuracy of the diagnosis in lung cancer. 80 cancer cases and 160 cancer-free cases were given for study to 15 radiologists. Chest X-rays with lung cancer or normal were part of the study. 75% identified cancer correctly. No radiologist identified all 80 cancer cases correctly. This is almost the last chapter. Money, marketing, and medical decision. Some pharmaceutical companies are striving to change the way doctors think about health and disease. They not only want their products to be prescribed, but want to expand scope beyond accepted medical science. They target opinion leaders amongst doctors. From drugstores, they get information of prescribing patterns of physicians. Here is one company that developed questionnaire to identify men with low testosterone and gave doctors these questionnaires to fill. And then they put several advertisements in lay press and medical journals about low testosterone. And company markets pills, injections, dermal patches, and gels of testosterone. So is this medicine or just marketing? Testosterone levels fluctuate during day in young healthy male. Even it starts declining after age of 40. 1.2% decrease per year. This is normal aging and not a disease and does not need treatment. Even small deviation from behavior is labeled as psychological disorder and are put on medication as obsessive compulsive disorder or attention deficit hyperactive disorder. So marketing, HRT prescriptions are rising because of marketing. They are causing increased risk of cancer and heart attack. In fact, when Dr. Wilson was given large amount of money to publish on estrogen and menopause, drug companies whose goal is profit can drive doctors thinking what constitutes a malady and how to remedy it. The biology of aging involves many physiological systems, changes in many molecules. Fixing on a single molecule like estrogen as remedy is naive and potentially dangerous. When there is a complicated problem, there cannot be a simple solution. When there is a new product, it should be tried by doctor on one or two of his patients after learning its potential benefits and side effects from marketing company. Because it is rare for physician to read in depth about new drugs. One does not need costly drug for indigestion. Simple antacid works as well. Understanding biology is important. William Halsted pioneered radical mastectomy for treatment of breast cancer, and many of surgeons of my time performed radical mastectomy in cancer of breast, and it became standard of care under mistaken belief that cancer spread is contagious. Now it is shown that cancer spreads throughout the body early in the disease by lymphatic and blood vessels, and lumpectomy, radiation, chemotherapy have become standard of care in breast cancer. Spinal fusion is performed to alleviate low back pain. CT scanning and MRI are used to make the case for surgery. But there is poor correlation between degenerated disc and low back pain. After the age of 40, 27% of healthy people had herniated disc, and 50% had significant anatomical change on CT scan. Spinal instability is given as a diagnosis to justify surgery and cannot be directly disproved or challenged. There are no prospective and randomized control trials to compare results of spinal fusion and conservative physical therapy. So there is a push for surgery from device manufacturers and fresh spine surgeons. However, trial of new implantable device or new drug is possible only with healthy relationship between industry and medical profession. Business wants to get more profit. Doctor has to advise what is in best interest of his patient. So healthy relationship is essential for medical progress. And this progress is also in interest of patient. So there has to be an informed choice. Is it a standard treatment or there are multiple opinions? Science, tradition, financial incentive, personal bias, etc. mold the thinking, and doctor and patient should be very clear about outcome they desire. They should be clear about what is known and what is unknown in science. We all know about Memorial Sloan Kettering of New York. It's a massive 21-story structure. For year 2005, they had 21,000 admissions. How it started? It started with plight of a single young woman, Elizabeth. She had sarcoma of hand. Before that, she started having pain in hand, which was thought to be because of tendinitis. The treatment of tendinitis was done. There was a recurrence when biopsy showed there was sarcoma, had amputation of forearm, but she died in a year of secondaries. John D. Rockefeller considered Elizabeth as his adopted sister. His philanthropy resulted in starting of Memorial Sloan Kettering Hospital. Patient A had a large cell lymphoma successfully treated 2 years ago with chemotherapy. But after chemotherapy, now patient has myelodysplastic syndrome. So there is abnormal cell production. He has intermediate risk on international prognostic scoring system. But his WBC count was rapidly falling from 3,200 to 1,900 in birth. He needs regular treatment according to the prognostic scoring system and not just a supportive treatment. Scoring systems and algorithms are good for organizing and assessing complex disorders, but individual cases have to be treated differently. This patient required urgent bone marrow transplant and not just supportive treatment as indicated by scoring system. So the surgeon says, I tell patients I will do everything possible to help them. That means my attempt may also fail. Patients of prostate cancer who have aggressive disease are likely to end up with impotence or incontinence because of extensive surgery. But that is the best chance for them to have a cure. More aggressive the disease, more aggressive the surgery. T-cell lymphoma, the way physician phrases his recommendation can powerfully sway patient's choice. Case B has T-cell lymphoma, which was not responding to standard chemotherapy. He is treated by high dose of cyclophosphamide, to which he responds. Then he is subjected to bone marrow transplant with his own stem cells. Luckily, the disease disappeared for 6 years. After 6 years, it returned in form of mass in axilla. Because it was localized, it was treated by radiation. But after 2 years, lymphoma returned in bone marrow. But patient B urged, I have so much to live for. Please keep me alive. So he was accepted that for a second transplant. He was told that accept that without a risk of failure, there was 0 chance of success. So after second transplant, he lived 1 more year with recurrence in abdomen. And then there was no possibility of further treatment. So just because you can treat someone any longer for his cancer does not mean that you stop treating him. At this stage, treatment is most challenging. How to balance control of pain with safe drugs without sedating that one is unaware of surrounding and unable to communicate with loved ones. How to give words of comfort while speaking the truth that end is approaching. Therapy has progressed well, but some physicians and patients are obsessed with side effects and are reluctant to undergo treatment. But physicians should explain that let us start the treatment, we will stop if there are side effects. We need to combat cancer. Their choice has to be consistent with this philosophy of living. I read the recent literature for a non-clinical case or variation of diagnosis. I try to remain on top of my game. I love to read medical literature and tell my patients to wait for a day before I give them diagnosis and treatment. In advanced cancer, I stop futile chemotherapy and put them on comfort care. However, looming behind every high-risk decision in today's medicine, there is specter of litigation. But a physician is not great if he abandons patient when he clinically deteriorates. Some abandon the patients out of fear of death. Understand character of the patient and factor this into clinical judgments. In cases of cancer and other serious diseases, what path patients choose will largely depend on clinical facts and character of their own and their treating doctors. My thinking about patient is guided by the patient's and family's concerns, free from influence of financial gains and those who see medicine as a calling. Complicated problems cannot be solved in rush. Good thinking takes time. Thank you.
Excellent, sir, as usual.
Yeah.
Very good and very simplified messages from a very good book. So Niranjan had a lot of comments written in the chat box. Niranjan, if you can speak out, it's good. Otherwise, I can read out your comments and then we can carry on with further comments by others. It's a very interesting topic where everybody would have his or her own opinion. And there may be some differences from the author also. Like, sir, I personally believe that there is a lot of bias against certain practices and or medicine and a lot of skepticism about the role of industry. I mean, if the lay people read this book, it will further their mistrust in the medical system, and that's my personal observation from whatever you read out from the book.
Yeah. Yeah, but author has written this book for the doctors and general public.
Niranjan, are you there? No, probably he has left. So, but he has made some comments.
Yeah.
I think they are worth reading out. So I'll just read out. Cognitive functions and communications are vital pillars of clinical efficiency. Niranjan is there. Niranjan, would you like to speak or should I read out? You are muted. You are muted. You have to unmute.
Okay. Are you able to listen? Yeah.
Yes, yes. Now we are able to listen.
Okay. As always, I think listening to JNP sir and Satish Pandya, I see Hemant sir also is always a great learning experience, not only in medicine but in life. Everything what sir has said is very true, and I think. But the sad part of it, many of us we don't do it over there. And Dr. Satish's concern is very right when he says that. In our society, there's a lot of mistrust in the patients, particularly with the digital media and the social media platforms. So what I think, where one patient told me yesterday, ki, sir, this I have read on Google and this thing. So I politely said to him, it was some complex issue. He had consulted me for second opinion. So I told him, look, you look for Google, but I have studied over there for likes of me have studied for many decades, and we don't look to Google, we look to UpToDate and we look to PubMed. So at least, I mean, he asked me what is PubMed. So I told him what is an RCT. He was a postgraduate. So I told him what is the importance of PubMed, because he was an engineer, so he knew about RCT, double-blinded trials. So, but that happens rarely. But everything what sir said is true, and what Satish says is really a pertinent point. And we all know, and what I can just end up, because there were a lot of comments that at least in my disease, which I have been suffering from chronic relapsing disease. So once, I mean, that doesn't mean that we have it over there. But suppose, unfortunately, I think that makes us more sensitive to at least this part, because on the one side we are as the doctors, but when we become the patients, no, so it does add over there, but at a cost over there. But sir, I think as usual, it's a great experience. Thank you, Satish, and thank you all of you. Thank you, sir.
Thank you, Niranjan, for these comments. Anybody else?
I have not read. I think you can read. They can all read over there if you want over. Yeah. Shall I mute myself? Shall I mute?
Yes.
Oh.
Any other comments?
Jagdish,
Good morning, Jagdish.
Morning.
Having two Jagdishes together on a panel is always a great pleasure. It's such a pleasure to listen to both of you. Yeah, Jagdish, your comments.
Yeah, I think excellent lecture and a summary of Groupman's book. I think there are two or three things which are the underlying philosophy. One is the degree of uncertainty.
Right.
So that is one thing which sir mentioned very briefly. The book which made a lot of difference and which won the author the Nobel Prize was Thinking Fast and Slow. And in thinking by a very famous Israeli scientist, this book is again what we do in practice. There are times when we have to take decisions at the split moment. We cannot wait to take decisions like an emergency room. And there are times when you can sit back and look at the diagnosis and make a think about all the consequences, possibilities, and make a diagnosis. So this book, again, I would request, by Daniel Kahneman, is a very, very good book which all of us should read on how to think fast and slow and what are the difficulties in each one of these. The second thing which sir alluded to was the question of bias, cognitive bias, and that he mentioned very briefly about a gentleman called Pat. Actually, it refers to Pat Croskery, who has done he's a Canadian physician who has done most of the research on how cognitive bias affects the medical decision making. And this is a very, very interesting articles are there on the web. Pat Croskery's, who looks at cognitive bias, and you wouldn't believe it that all of us are at least prone for more than 100 different cognitive biases in different ways. So each one of us is very different. The third point which I wanted to make, which I was reading, recently, sometimes I, wonder, can I become like Dr. Satish Pandya or like Dr. Amdekar? Is it possible? My personality is so different compared to somebody else. So as sir mentioned, each physician has his own personality. So can we change our personality somewhere in the middle of our practice? Is it possible? So there is an interesting article in the Atlantic last week on a lady who tries to change her personality. So she breaks it down into what are the different components of her personality and what are the defects in her personality. So I know it is very superficial, but what I'm trying to say is that these are all questions which we need to probably reflect on somewhere. So thank you, sir, for that wonderful Saturday morning session. I was on YouTube, so that's why I was not visible on Zoom. So thank you very much, sir.
Yeah.
Thank you, Jagdish, for those comments. Any comments from Jagdish Bhai on what Jagdish said?
No, it is very interesting, and what he referred, Dr. Payat, he is studying physician's cognition, and naturally he will come up with an excellent observation. But one thing important about the book is that every case is different, and algorithms and scoring systems do not apply to every case.
Jagdish, it's a long overdue that now you present a book review on the same title what you talked about.
Yeah, he can review the book which is suggested
Yes.
all of us to read.
Yeah, I will give me some time because this January is very, very busy. I have too many
But
engagements.
keep in mind that you are on my list.
Yes, sir. Yes, sir. Yes, sir.
Yes.
And
Dr. Praveen wanted to say something, and then Dr. Niranjan. Yes, Dr. Praveen. साहब unmute कर दो साहब, तमें कहीं कहता था. अच्छा, okay. Please, Niranjan, go ahead.
There is another similar one good book which is written in 2009, and she also mentions this Dr. Groupman's book because Dr. Groupman's book came out probably before that. So Lisa Sanders is MD Medicine in US, and she has written a story somewhat similar, short real stories. Each patient tells a different story. It is a very popular book. It is available on Amazon, and I am very sure that whenever whosoever reads it also would find it very, very useful to improve our, particularly nowadays, most of the books, and I think they are more and more talking about our cognitive functions, whether it is a pilot. I read that in Indigo when I was boarding an Indigo flight around 1 year back. So on the door, there was a sticker. Flying is a serious business. For those sticker, door means the cockpit door. Flying is serious business. Dear pilots, please leave your worries outside. So I think we probably in the same. Thank you.
Thank you. So thank you once again, Jagdish Bhai, for a wonderful review. And we end the session here. We meet again next Saturday, and we have Dr. V.C. Chauhan, a very well-known cardiologist, talking to us next Saturday. So we meet again next Saturday. Thank you all. Yeah, Hemant, you wanted to say something?
One point only.
Yes, please.
One point. All these books are written by people who are no more in practice and they have themselves committed mistakes. And they should be writing positively and gratefully about progress of medicine. And they should be adding to the glory of the medical profession, which diagnoses more and treats better to the world, doctors, than the past 10 years or nothing. Second point is, cancer has taught us that multidisciplinary tumor board always helps, and we always have to stop and stare and reassess ourselves. So if everybody of us takes a multidisciplinary approach, then we are likely to commit less mistakes. And Atul Gawande is better, and checklist reassessment always helps. Thank you.
Thank you, Hemant, for those very useful comments. Thank you all. So we end the meeting here.